we? I'm just trying to think. Because it was Veronica Montes de Oca who suggested you for this. Do you work with her in the Autonomous University of Mexico?
Yeah.
Ah, okay, okay. And is your background specifically on elder abuse or on a range of different issues?
Sorry, again, please.
¿Estás trabajando más que nada en el abuso de las personas mayores o en muchas cosas?
En cuestiones de abuso, de aging, and about the caring also.
Okay, okay, well, excellent. Yeah. And where do you do your field work?
At the university at UNAM. In the I work in the bachelor degree of communitarian development towards aging.
Okay. And ¿dónde haces tu trabajo de campo?
In different spaces of Mexico, rural, urban, and also indigenous places.
Okay, so a very big range of different experiences.
Yeah, yeah.
That's
My
interesting.
experience is more in the communitarian spaces, and I work in an interdisciplinary team. We work since, I don't know, 15 years ago about this. Yeah.
Oh, well, I must follow up with you about some of this work. It sounds very interesting. And Elsie, I don't think I've met either you or Risa before either. Is your research based in, is the fieldwork conducted within Hong Kong, or is it conducted across wider communities in China?
Hong Kong and China.
Okay.
Well, yeah, mainly in Hong Kong because I'm based in Hong Kong, but I have worked with a couple of my former students who graduated and then they are now teaching in Shanghai and Guangzhou, all those places. So we conduct research in China as well.
And do you find particular forms of abuse before, before we had to worry about coronavirus, did you see particular forms of abuse that were more prevalent in China than perhaps in other parts of the world where abuse has been more widely researched?
I would say it's pretty much similar, but then we see lots of financial exploitation in China because children, they have this sense of entitlement. Like they feel whatever my parents accumulate, whatever wealth they have would eventually be my money. So they have this feeling that like they are entitled to spend the parents' money.
That's really interesting. And again, that links into some work that I was involved with a little bit with Carl and Bridget in the past. And again, it would be very, very interesting to follow that up as well. I think we're getting quite close to kickoff time, aren't we? Risa, you're going to talk about deprived communities. So do those include immigrant communities, or is it more African Americans? What sorts of communities do you work with?
So the New York City Elder Abuse Center at Weill Cornell Medicine works with primarily professionals who are working with elder abuse victims. And we do case consultations to them. So we really work with the entire city. We also have a helpline for family, friends, and neighbors of elder abuse victims. They can call in from anywhere really in the world, as long as they're calling about an elder abuse victim residing in New York City. So we don't have a particular community or area of the city we work in. We're really working in all of the boroughs.
Do you see more? Do you get more sort of reports of abuse in poorer communities, or you don't see any kind of socioeconomic gradient of this in terms of what you hear?
We have to add, we've been collecting data for, probably now a couple of years, and we're getting ready to analyze that data, but I'd be hesitant to say, because I would just be, it really wouldn't be based on an analysis of the data. Our sense is that, we really are seeing a wide range of cases from around the city. Yeah. So stay tuned on that, I think.
Oh, absolutely, yeah.
Yeah.
Guys, I think it's time to get started. So, Lucas, would you mind putting up the PowerPoints, please?
Yes, just a second, please.
If I could interrupt a second, I've had a message from Carl asking if we can see that he's joined the meeting, but we can't see him at the top at all. So I'm not quite sure if we can do anything about that as well, Lucas, after you've done the PowerPoints.
Yes, I can. Just a second, please.
Thank you.
Well, hello everybody, it's Peter Lloyd Sherlock again here, and welcome to what I can't believe is the 8th consecutive weekly webinar of the global platform. And this week we are going to be looking at the very important issue of elder abuse and coronavirus with a focus on low and middle income countries. Next slide, please. As I always do at the start of these sessions, I think it's always useful just to provide a little update on the status of the pandemic in the different countries that we're going to be looking at in a bit more detail today. And I think looking at Mexico, the USA and China, we're looking at 3 very radically different scenarios. I don't think you could have chosen 3 countries where the situation is playing out more differently. So Mexico is seen officially 8,500 deaths, probably rather more in reality, and we're seeing a rapid increase in the number of cases and number of deaths over the last few weeks. We all know, I'm sure, about the United States, which has seen over 100,000 deaths, and a bit like in my own country, the United Kingdom, the rate of infection is going down, but it's going down really quite slowly. And of course, there are concerns about a second wave of infection. China stands out as a very different scenario in that since the end of February, there have been almost no deaths at all from coronavirus. And so it's useful to keep those contexts in mind when we look at how the pandemic has affected behaviours and issues such as elder abuse in these very different country settings. Next slide, please. On social media and among UN agencies and other NGOs and organisations, there's been a lot of attention paid, quite rightly, to the issue of domestic abuse in context of lockdown. And this is almost exclusively viewed in terms of gendered dynamics. And clearly that is an extremely important issue and deserves all the attention it's getting and actually should be receiving more. But it is important to point out that within that, almost no reference is being made to coronavirus and elder abuse, especially in low and middle income countries. And I think this is clearly, it's an issue which is neglected at the best of times. And I think it's even more important and therefore even more neglected in the current situation. There are a number of reasons which I'm sure are not very difficult to establish, in terms of why we should be concerned about elder abuse in the current situation of the global pandemic. And here are just some quick examples. Next slide, please. Clearly, lockdowns don't just affect older people, they put entire families under severe economic distress. And we have to ask whether that increases the risk of financial abuse, which we know is the most prevalent form of elder abuse in most parts of the world, of older people by their own family members. And identifying financial abuse is extremely difficult. Where do we draw a line between consensual economic cooperation within households towards more persuasive, more coercive, and more abusive forms of appropriating income from older people? So this is a very difficult issue. Next slide, please. It's difficult to find out about domestic elder abuse at the best of times, to conduct research which can ethically and reliably report on these issues. But I would argue that in the current situation, it's almost impossible to find out what's really going on. As we all know at the moment, the main way we can conduct fieldwork is through telephone surveys. And this begs the question, how can you run a telephone survey of domestic abuse as older people sit in the same room as the families they're experiencing lockdown with. I know a few weeks ago in Brazil, they set up a new hotline for domestic abuse, which made specific provision for older people, which was a very welcome development. And from what I've heard, it's received a lot of calls from older people who live on their own and feel neglected and lonely and depressed, but almost none from older people who may be experiencing abuse within their own homes from the people who are living there with them. Next slide, please. And of course, we all know that elder abuse happens much more frequently than people would like to believe in nursing homes and care homes. And we know that care homes are at the epicenter of this pandemic. But there's been almost no reference to how coronavirus in care homes and the often perhaps rather brutal responses to this threat may have promoted, may have led to elder abuse within these settings. And it's almost as if this is a luxury concern that we just can't worry about because there are far more immediate concerns, and this is just something we'll have to come back to and address once the worst effects of the pandemic have passed. So these are just some examples of issues that we clearly need to give a lot more thought to and a lot more prominence to than has currently been the case. Before I hand over to our chair and moderator, Bridget, I just invite Lucas, next slide please, who will do his usual explanation of how we'll handle questions and answers and general housekeeping during this session.
Thank you, Peter. Before Bridget chairs the session, there are two main ways of asking questions and making comments. One of them are in the chat. I will be checking it, and at the end, Bridget and I, we can liaise and read the questions and comments to the panelists. Or there is another session, that's the Q&A session. You can make questions there, they will be recorded, and then they will be answered. That's it.
Thanks, Lucas. Next slide, please. So I'm now delighted to hand over control of the session to my good colleague from the University of East Anglia, Bridget Penhale, who's a reader in mental health. Sorry, this isn't a very clear image of Bridget, but this is Bridget 2 years ago addressing the UN Open-Ended Working Group on Aging, where she was providing expert information about elder abuse. She's a fellow of the International Network for the Prevention of Elder Abuse. She's done a lot of very relevant research in the UK, particularly in social care settings, and also has a range of international interests, including research she's been involved in countries like Argentina. So it's a great pleasure to hand over to Bridget, who I'm sure is going to do a wonderful job of chairing and moderating this session. Over to you, Bridget. Hi, Bridget. I think we need your microphone on.
No, I think my microphone's on actually, Peter. It's just I'd lost the top screen momentarily, so apologies for that, everybody. Welcome everyone to this webinar on elder abuse in low and middle income countries. We are delighted this week to have 3 presenters from different parts of the world, and without further ado, I'd like to move into the session proper. Our first presenter is Elsie Yan. Elsie has a background in psychology and is a trained psychologist. She's currently an associate professor in the Department of Applied Social Sciences at Hong Kong Polytechnic University. Her research interests include elder abuse, dementia caregiving, and elder sexuality, and her presentation this afternoon is entitled Elder Abuse in Chinese Populations, the Impact of COVID-19. Elsie, the floor is yours. I think you're muted, Elsie, if you'd like to.
Okay, yeah. Thank you, Bridget, for the very kind introduction, and thank you again for having me. Yes, can you see the share screen that I'm doing right now? Okay, good. Right, so today I'm going to cover a little bit about elder abuse in Chinese population. And, okay, sorry. Okay, so COVID-19, Peter gave us a very good background information already. So first identified late 2019, and then right now we already have 3.1 million confirmed cases and many deaths. And authorities in Hong Kong will use strategies ranging from suspension of public activities, concerts, gatherings, etc., closure of high-risk premises such as karaoke, bars, and restaurants, and then quarantines. So we request people with close contact with confirmed case to quarantine themselves for up to 2 weeks. People traveling from high-risk places to place at quarantines as well, to complete lockdowns of cities. Because we don't know like how it spreads. So we're using all these measures in hopes that we could control the spread of the disease. And you have probably seen this image in social media. So if you could identify the association between two objects, you are at higher risk of dying from COVID-19 than the average population. I think most of us could identify like the association between the two objects. And if we look at the data, COVID-19 is particularly risky for older population. We are looking at like people at advanced age at much greater risk of dying from coronavirus as compared to other age groups. So it is very relevant to the older population. And my opinion is that COVID-19 and elder abuse are also closely related. First off, COVID-19 exacerbates the impact of some of the known risk factors that we saw in existing research on elder abuse. And then it also creates new avenues for elder abuse. Like there are new opportunities for abuse to happen. And it also brought light to some of the long-standing discrimination against and disadvantaged position of older persons in the community that have been there for a very long time, but then we may not have paid enough attention to. Okay, first off, I would like to talk a little bit about elder abuse and its treatment in the domestic setting. Between February and May, many employers in Hong Kong, they offered work from home arrangement to their employees. So instead of going back to the office, they could choose to work from their computer at home or stay home to do other stuff. So a small-scale study have been conducted in Hong Kong. And then before COVID-19, only 10% of them said that they were offered work from home arrangement. But then after the outbreak, up to 88% said they were able to work from home. My previous research in Hong Kong suggests that number of co-residing days is a risk factor for elder abuse. So if a lot of people are working from home, that actually increase their interpersonal contact, and there is a chance that they may have more interpersonal conflicts, which could eventually result in increased elder abuse. And then another thing that I want to talk about is cessation of public service. During the COVID-19, lots of the public services were stopped. And in this slide, I'm showing pictures of advocacy groups holding a press conference asking the government to resume these services. So during the COVID-19, most services such as home help, Meals on Wheels, etc., daycare, they were all stopped. And so the care responsibility remains with the family. And then also in my previous study, caregiver stress appears to be a major risk factor for elder abuse, especially for older person with mild cognitive impairment and dementia. So while the pandemic have stopped caregivers from receiving social services, I feel that would impose extra stress to some of the already stressed caregivers. And again, that may increase chances of elder abuse. A very interesting phenomenon in Hong Kong is people started wearing surgical masks very early on. And so people were trying very hard to get hold of some surgical masks. And what we observed is that it is generally older family members in the household being sent to queue up for those masks. So in this slide, I have pictures of this lady in pink. She arrived at the store 3 a.m. in the morning in order to queue for her turn to get the surgical mask. And she ended up being third in the queue. And then another lady being told that the store ran out of stock. The reporter did a follow-up interview with her, and apparently she was in all tears. And then like some good-hearted lady gave her like 10 of the priced surgical mask she got. Well, both of them obviously were older ladies. And this is the picture on the left is an average queue in Hong Kong, people queuing up for getting those surgical masks. And then on the right, a lady taking her small chair out to her seat out to wait for her turn. So if you look closely at a queue, most of the people queuing up to purchase those masks were actually senior citizens. What caught my attention is that older person, they may be disadvantaged because they do not have the knowledge or resource to do the shopping online. And some of them may feel obliged to go stand in that long queue to get hold of the mask because like younger family members, they may have other responsibilities, so they feel they are pressed to do that job. However, these queues are generally packed with people, as is obvious, so that actually put them at greater risk of contacting the virus. And then I would also like to talk a little bit about elder abuse on the societal and structural level. Homeless older people. This is a public park in Hong Kong which houses 70 to 80 homeless people, and many of them are senior citizens. And what happened is on March 27, the Hong Kong government issued a policy which banned gatherings of 4 persons or more. So you could be at a restaurant, you could be on the street, you could be going hiking, but if you have 4 persons or more in a group, they would give you a ticket and then you need to pay a fine. And with that policy, many of the restaurant and fast food chains, they actually closed during the time. And in Hong Kong, we have a very special group of homeless people that we call them MAC refugees. So they would spend the night staying at McDonald's because it is a relatively safe place. The temperature, well, there is air conditioning, and they could find the seats. But then the closure of all these places actually forced them back onto the street. And at the same time, many of the public facilities, such as showers in the park, basketball courts, etc., they were closed during the COVID-19 situation. And that actually results in some sort of hygienic problems because they can't go to those places to clean up themselves anymore. And then there are social distancing measures. So people, groups, volunteering groups who provide services to this underprivileged group regularly, they actually stop the services, and that further disadvantage the all homeless people. And then hospitals and aged care facilities, in response to the COVID-19 situation, they actually banned all visitations. So family and friends, they could no longer go visit their older family members or residents at nursing homes. So the residents will lose their support and social networks during the pandemic. And this obviously increased their sense of loneliness and depressive feelings. And the change could be particularly difficult for older persons with dementia who may not be able to understand what is going on. And this is one of the nursing homes where the staff were assisting 2 residents to connect with their family member using FaceTime. But again, this is pretty rare because many facilities, they are very understaffed, and then staff may not have time to pay like one-on-one attention to individual residents. And in Hong Kong, we also have lots of older workers in low wage, low skill industry, toilet attendants, sanitation workers, etc. And many of them do not have any income protection. And obviously COVID-19 actually brought about like a very big economic downturn. And these workers, when they get laid off from work, it is very unlikely that they will be able to find new jobs. And for those lucky few, quote unquote lucky few, who could keep their job, they may not be able to work with proper protective equipment. So picture on the left, sanitation worker trying to clean up the streets. Some workers reportedly use second-hand surgical masks. So surgical masks they find in a trash bin and reuse it. And some were forced to wear the same surgical mask for days. And if we look at the picture on the right, these are like packs of boxes of surgical masks, priced at $230 per 50 pieces. And many of the sanitation workers, they were actually receiving minimum wage, which is $5 per hour. There is no way they could afford to buy their own protective equipment. So yes, janitors, toilet attendants, sanitation workers, the nature of their work actually require them to work at high risk environment with high risk of exposure to COVID-19. But apparently they were not really well taken care of. A survey of 149 sanitation workers showed that 30% of them were not given any surgical mask at all. And 40% of them were only given one surgical mask per day. Most importantly, 85% say that they had not received any training in relation to COVID-19 before they carry out their work. So we believe that COVID-19 provides us an opportunity to rethink and reflect on elder abuse issues beyond the domestic setting. I am happy to share that right now we are conducting a telephone survey to look at elder abuse in the COVID-19 pandemic in Hong Kong, and it will be completed in mid or end of June. So I'm looking forward to share more data with you. And then we are also doing a new project to look at elder abuse prevention and intervention in Hong Kong. Hopefully that will help. And at the meantime, we hope that the advocacy efforts for elder rights will continue. This is the end of my presentation, and that is my email, please.
Thank you, Elsie. I suggest that in the interest of time, we move straight on to our next speaker. So thank you very much. I'm sure there will be some questions and people wanting to know more about the situation in Hong Kong that you would be able to tell us more about later. But right now, I'd like to pass to the next speaker, Marisa Vivalda Martinez. Marisa has a degree in international relations from the National Autonomous University of Mexico, and her PhD studies in collective sciences and collective health was from the Autonomous Metropolitan University. She's a professor in the Faculty of Higher Studies Zaragoza at UNAM, and she's a founding member of an interdisciplinary seminar on aging and old age and a member of the University Network on Aging and Old Age. She's participated in research projects, designing public actions and educational programs related to healthy and active aging, communitarian development, prevention of ageism and health promotion. And her talk this afternoon is entitled Elder Abuse During the COVID-19 Pandemic in Mexico. Thank you very much, Marisa. The floor is yours.
Thank you, Bridget. Good afternoon to everyone. And on behalf of my colleagues in Mexico, I want to thank this opportunity to share experiences and ideas about this important subject. For the Interdisciplinary University Seminar on Aging and Old Age, the Promotion of Human Rights and the visibilization of the elderly is a commitment. Then the purpose of this presentation is to show an overview of the different areas of abuse towards older people that exist in Mexico, and also to make visible the fact that the pandemic caused by COVID-19 has placed older people in a situation of a greater vulnerability to abuse and violence. The next, please. As a context, Mexico is a country of more than 125 million people, characterized by diversity and cultural wealth. However, it is important to recognize that Mexico is also a space in which relations of inequality, inequity, and discrimination have historically been reproduced. The only 9 years of average of schooling of our population show a situation of structural lag that, despite the effort for reaching progress, continues to keep our country far away from development and well-being for all. In Mexico, more than 50 million people live in poverty due to low incomes, poor access to health services, education, decent employment, poor access to justice, among many other problems. Then we can say that in Mexico, a good part of the population ages in poverty, in condition of vulnerability, and with a few opportunities for development. The next one, please. On February 1920, the first two COVID-19 cases appeared in Mexico, and in the middle, they appear in the middle of a social movement of protests against violence and femicides that sadly plagued our country for more than 50 years. 1 month later, the Mexican government established a period of voluntary confinement with a duration of just over 2 months. Next one, please. Despite the effort of individuals and communities, more than 78,000 infections have occurred and 8,500 Mexicans have lost their lives. It's very important to say that more than 50% of these deaths were in people over 60 years old, as we can see. The next one, please. It is very important to point out some events that had been taking place before the start of the pandemic. First, as I mentioned at the beginning, Mexico is characterized by being a country where discrimination is a common fact. 20% of adults in Mexico have felt discriminated at least one time in the last year. Among the most frequent causes of discrimination we can find are low schooling, health status, the type of work performed, and not having a social security. This situation increases, of course, in the group of older people. Almost a quarter of people over 60 have felt discriminated, not only in the community or in the family, but also by authority, and that's very important. The next one, please. In addition to discrimination, older people are especially vulnerable to crime. Between 2014 and 2016, the National Human Rights Commission recorded of a total of 34,000 crime-related complaints affecting older people, of which almost 3,000 were committed by family members. Major crimes include the following: property-related, as Peter said, domestic violence, injuries, threats, homicide, and other like rape, sexual abuse, kidnapping, abandonment, omission of care, medical liability, human trafficking, exploitation, and discrimination. Next, please. In this period of time, elderly people presented a total of 5,000 complaints related to violation of their human rights to legal certainty, health, social security, due process, and quality of attention by public services. It is important to point out that in Mexico, not every crime is denounced. The main reasons are fear, distrust of authority, and fear of re-victimization. Some studies estimate that the number of complaints does not represent even a half of the crimes. Other estimates that at least 1.5 million elderly people in Mexico suffer from mistreatment and abuse, especially in the case of women over 80 years old. Next one, please. So, in Mexico, older people face different forms of cultural, economic, and social difficulties that lead to multiple situations of vulnerability, either individual or collective. That is, they are victims of double or triple discrimination, which represents an annulment or impairment of their human rights. Next, please. Within the group of older people, there are undoubtedly people whose circumstances, condition, or disadvantages make them a kind of ghost for the family, the community, and the society. So women with disabilities, for example, and elderly women living in institutions, in nursing homes, psychiatric centers, and in residential care homes are also at higher risk of violence and abuse due to a general lack of external supervision, particularly during this pandemic situation. Next, please. Data indicates that the elderly feel especially discriminated when looking for a job. Since the last decades in our country, government institutions have promoted the idea that the elderly just carry out simple activities that do not require specialization, such as packing groceries in supermarkets or doing cleaning work. In last year, a study, The Worst Wages from the Most Discriminated, reported that women, people with disability in indigenous populations, members of the LGBTQIA+ community, and of course, the elderly face enormous barriers in having access to a decent employment. And it's stressed not because their lack of labor skills, but because of companies' criteria that discriminate against certain traits. In Mexico, 2.5 million of people over 60 work, mostly because of necessity and unfortunately under deplorable conditions. Next one, please. The discrimination against people with disability is also very high in our country. Therefore, aging with a disability implies living with a double process of mistreatment, violence, and abuse. I'm presenting the case of Juan here in the picture. Juan is a 62 man who has Parkinson's disease since he was 45. And in Juan's cases, as is common, the circumstances of discrimination forced him to have an informal and precarious job. And in COVID times, when he needs government support in absence of income during quarantine, due to a discriminatory argument accompanied by institutional abuse, this support was denied. The next one, please. Another huge problem, as I said, is violence against women. But violence against older women is the result of lifelong accumulated disadvantages aggravated by poor health, poverty, discrimination for being a woman, ageism, and the lack of access to education. Since the onset of the quarantine due to the COVID-19 pandemic in Mexico, at least 163 cases of feminicide have been reported. Data about femicides are of older women are not completely clear, but I want to say that it is a reality. So we are constantly claiming for justice for these old women. The next one, please. Another problem is that there are regions of the country that are suffering violence due to drug trafficking cartels, guerrillas, and paramilitary organizations. This situation has forced entire families to abandon their homes and move to other spaces in the search of survival. During the pandemic, their conditions have worsened because they do not have a home, access to water, health services, or even food. It is very important to carry out studies of the situation of displaced elderly in Mexico. Next one, please. Then, what happens when the main strategy to face the pandemic in Mexico is it could be synthesized by the phrase "stay at home." An estimated of 4,000 people are homeless in Mexico City, just in Mexico City. They include children, youngsters, elder people, trans people, people with disabilities, and with various health problems and addictions. As I said, the Mexican government's strategy for containing the pandemic is to invite all people to stay home. But what happened with homeless people? In the different cities of the Republic, that strategy is simply excluding these people of this idea. Their health condition now is completely exposed, and there are neither strategies nor resources to assist this population. In this sense, institutional invisibility is also a form of abuse and mistreatment, of course. Next, please.
Marisa, can I just let you know that you've got 2 minutes left?
Perfect, thank you. The next one, please. Let's go to the final in order to finish. The next, please. And the next. In order to include this presentation, I would share with you that in Mexico, the institutionalized invisibility and the abuse against the elderly were perfectly clear in the first published version of the Critical Medicine Resource Allocation, a bioethics guide, published by the Sanitarian System, where it was pointed out that if during pandemic medical resources were reduced or scarce, the life of young people should be privileged under a criterion of lives to be completed. That was the most common phrase used to the guide promoters was older people have already lived, as if their present and future were not important at all. That's why from the university, we defending the following ideas. First of all, during the pandemic, human rights are not quarantined. Second, older people, by virtue of big people, must enjoy the same right of everyone else. And three, there are no futures more important than others, and ageism exists, and the government and institutions in Mexico must recognize it. Finally, thanks to the sensitivity to many institutions, especially the National Council to Prevent Discrimination and the support of members of academic sector, the guide was modified and it was established that no one can consider age as a criterion for deciding who lives and who does not. Thank you very much, Bridget.
Thank you very much indeed, Marisa. Without further ado, I'd like to pass to our next presenter, Risa Breckman. Risa Breckman is a qualified social worker and is the director of Weill Cornell Medicine's New York City Elder Abuse Center. Since 1982, she's been at the forefront of developing programs on elder mistreatment. Most of these have been very innovative. She also writes articles, educational materials, and thought pieces on the topic, including co-authoring a book, Strategies for Helping Out Victims of Elder Mistreatment, and was heavily involved also in writing the Elder Justice Roadmap report, which affirms that elder abuse is indeed a problem in need of many solutions. Her presentation today is entitled New York City's Elder Abuse Response During the COVID-19 Crisis. Thank you, Risa.
I do that. Okay. Hello, everyone. It's an honor to have the opportunity to present to you today on New York City's elder abuse response during the COVID-19 crisis. Thank you for inviting me to do so. Let's see if I can move my slides. I don't know. Okay, here they go. So I'm going to start my presentation with a mention on what was happening in New York State in mid-March. It was when all of New York State was focused on slowing the spread of the virus and flattening the curve to reduce the number of people needing health care. So on March 20th, New York State's Governor Cuomo called for a sheltering in place order. This mandated that any business not deemed essential must keep 100% of their workforce home. It also required that all non-essential gatherings be canceled and that anyone going outside maintain at least 6 feet of space between themselves and others. And that day, life changed drastically for everyone in New York State. I just wanted to touch on briefly the impact of COVID-19 on older New Yorkers, as this is the context for our conversation today about elder abuse response during the health crisis. As of May 27th, there have been 21,415 COVID-19 deaths in New York City. About 73% of these deaths are of people in the age group 65 and over. Hispanic and Black people have suffered the largest majority of COVID-19 deaths in New York City, with the greatest number of these deaths being among older adults. There have been numerous articles reporting on significant social, health, and economic disparities that explain why these populations are being severely impacted by the virus. So we know that COVID-19 is hitting older adults hard, and we also know from news reporting that it is hitting low-income and communities of color in New York City the hardest. This is the bleak COVID reality picture we are experiencing in New York City. And now I'm going to bring elder abuse into this already bleak picture. And so I want to talk about what does COVID-19 mean specifically for elder abuse victims? First, it increases risk of harm, as outlined on this slide. Yet referrals to agencies went down over the last couple of months in New York City during the COVID-19 surge. We speculate that the sheltering in place requirements has resulted in limited access to medical care, limited interactions with family and friends, less access to social support structures like senior centers or houses of worship, making detection of mistreatment less likely there. Also, some older adults are without the aides they had previously, who kept eyes and ears on mistreatment situations. Those in nursing homes could not see family members, as the State Department of Health limited family access to facilities, and ombudsmen have not been allowed into nursing homes either by a government order, further isolating older adults residing in those facilities and making abuse detection less likely there. So with fewer people to identify and witness mistreatment, abusers have less deterrence, and so we really do think that abuse is on the rise, but again, we have not been seeing that in our referrals throughout the city. But some cases, have come through, of course. And during the COVID-19 era, responding to elder abuse, already challenging work, has gotten even more complicated. I'm going to share with you some examples of how COVID-19 intensifies the impact of elder abuse and complicates the response to it. These examples are from my organization's case notes, but they've all been de-identified. So COVID-19 has impacted dynamics within the household, including the alleged abuser's increased drug and alcohol usage, scaring the older adult. So this speaks to a clinical risk factor of the abuser. COVID-19 has magnified the impact of the abuse due to the older adult having to self-isolate. Before the pandemic, the client was clearly very active and used to be able to go out and do things to take his mind off the situation, but that now is not possible, and he feels like he just cannot cope anymore. This speaks to the dangers of the social isolation of victims caused by the virus. When the fights become quite violent, the older adult called the police, but when they responded, they said that they are not authorized to enforce the current order of protection by removing the relative because the courts are closed and nothing can be done at this time. This officer, unfortunately, had misinformation about his role of enforcing orders of protection during the health crisis. While courts are largely closed, arrests still are being made for order of protection violations, and arraignments are being held virtually. We discussed the potential dangers of the older adult going to a shelter and a nursing home during this time. Before the crisis, offering shelter would be part of safety planning in some cases, but going to the shelter based in a nursing home risks virus exposure. And to continue, the older adult's concerns about getting an aid are heightened in the COVID-19 environment. She has cancer and is at high risk for contracting the virus. She feels her choice is to be neglected by her son or get the virus if she hires an aide. This speaks to the difficulty of responding to healthcare needs of neglected victims. People in choosing between possible exposure to the virus versus being neglected. Older adult allowed a younger relative to live with her. Now the relative is telling her to stay in her bedroom and not come out, or he will make sure to bring someone with COVID-19 over to the house and expose her to the virus. This is an example of an abuser using the tactics of intimidation to control the victim.
Risa, are you on a headphone? It's making noise.
No, I'm not on a headphone.
Okay. Sorry for interrupting.
No, sorry about that. Maybe it's my page.
It just was rather steady, but if there's nothing you can do, don't stop your flow. Sorry.
No, that's okay, Carl. Thanks. After the governor's pause order, services changed rapidly. Changes which would have taken months or years occurred in a matter of days and weeks. For APS, the shift to working remotely was challenging. APS is mandated to investigate elder abuse and other reports. Just to give you a sense of the size of the operation, in 2018, the average number of cases under APS care was about 7,400. And they have a very big staff because they need it. They needed a lot of IT support to get tablets, smartphones, and laptops to staff. Caseworkers are utilizing a variety of video conferencing tools such as FaceTime and Skype to facilitate remote assessment. But because abusers can prevent older victims from having access to this technology, or the victim might not have a cell phone, or because of cognitive impairment or physical impairment can't communicate, home visits continue to be necessary to determine risk, eligibility, and the provision of appropriate services. Adult Protective Services initially had limited personal protective equipment, but they were able to obtain what they needed by mid-April. About the police. Before the virus, the police made wellness checks to homes with elder abuse victims, but this became much more difficult and reduced because of a need for them to redeploy resources. They continued to conduct callbacks, review 911 calls, and collaborate with community partners. Oops. The Emergency Room Elder Abuse Intervention Program, which we're fortunate to have, was closed to community referrals as the emergency room was the least safe place for older adults, and the ambulance service was needed to respond to COVID-19 cases. There was limited court access. The courts were closed except for emergencies. Housing court was closed except for emergencies such as lockouts. Emergency guardianship cases could be brought, but it has been challenging to get all the information needed to bring cases. Ombudsman, the eyes and ears on abuse situations in nursing home facilities, are prevented from entering facilities, as I said before. As a result, they must rely on phone or video chat to connect with residents. Unless a resident knows how to call the ombudsman for help, their access to such services is extremely curtailed. We have enhanced multidisciplinary teams in all of the boroughs, and we have 5 boroughs in New York City. They're like counties, and each team meets twice a month. These teams, with about 20 to 30 members, have been in person, and they bring together professionals from across disciplines and systems to review and coordinate complex elder abuse cases. In March, our staff engineered almost overnight the ability to meet virtually with these teams. In-person counseling services that nonprofits provide to victims quickly shifted to phone-based only, and this could be problematic when the abuser is in the home. So to coordinate in services in New York City, and we were all hearing about these rapid changes to service delivery, so we kind of sprung into action and started to tighten up our communications. The commissioner for the mayor's office to end domestic and violence holds bi-weekly phone meetings with over 100 providers in attendance to keep them all apprised of service changes and other impacts the virus has had on clients. People can ask questions through the chat feature, and then there are follow-up bulletins. Since March, NYSEAC, my organization, holds weekly meetings with elder abuse leaders and providers to keep each other apprised of service changes, to coordinate services, and to also discuss the process of how we are going to begin to go back to working in person slowly, which is quite a complicated process, actually. It was almost easier to shelter in place and start working remotely than it is to open back up. NYSEAC's enhanced multidisciplinary teams have been a place for providers to hear about updates in service provision and to find ways to provide services to victims, even with changes in service delivery and court closures. The teams have worked well remotely, and more people are able to attend now via Zoom than in person. So that's been a positive outcome, that we've had by working remotely. So the take home is it's imperative for communities to convene regular meetings with professionals responding to elder mistreatment cases as soon as possible, regardless of whether COVID-19 has yet reached the community. Creative solutions. So we have creative solutions. As I said before, working remotely has brought some nice surprises. More people can attend some meetings than ever before. APS has modified their intake process and protocol. They've suspended the central online form-based intake process that had been available. And by taking referrals by phone or email, they can now obtain additional case details, which helps prioritize cases. And they also need to know in advance the level of risk of COVID-19 exposure, which they're able to find out now using this intake method. Innovative law enforcement response has included reaching out via phone to known victims of elder mistreatment or domestic violence to help safety plan and implement code words for safety. And getting meals to people has been a massive effort in New York City. Taxis deliver food to older adults free of charge. Food stamps now are accessible online and by phone. Senior centers all call all participants regularly to check on them and to ensure they're receiving meals. And the city has obtained federal waivers so that benefits can be granted without meeting all of the previously required criteria, such as a face-to-face interview. So food has been, it's just been a huge problem, and workers who are working directly with elder abuse victims, obtaining food is often something that the workers need to focus on. Courts can do remote hearings, order protections are being issued, temporary orders of protections that were in place before COVID-19 did not expire. We have instituted virtual court parts for emergency matters. People can petition remotely for a new family court order of protection with the help of advocates and attorneys and family justice centers. And guardianship judges are working remotely on a rotating basis. We have a helpline that my organization runs, and we were already remote, so there was no change there, but we are getting many calls from family, friends, and neighbors. And most of those calls now are involving conversations about problem solving related to minimizing risk of COVID-19 exposure and keeping victims safe from mistreatment. And the city established a housing helpline staffed by legal service providers to help with housing problems. The shelter that's in a nursing home remained open and did more intensive screening, but referrals, of course, obviously were down. Providers conducted mental health services over the phone, including support groups for victims, which ended up working out very well. And there was a lot of support for frontline workers. Organizations have offered trauma counseling to assist staff and provide bonus pay. One agency is providing bonus pay to personnel unable to work remotely. Agencies are trying to offer mental health services to staff if needed. One agency, the managers check in regularly with staff to see how each are doing. And we just are kind of, muscling through. One last thing I want to say is that New York City's elder justice community co-wrote a paper which has been published online, open access, entitled Effects of the COVID-19 Outbreak on Elder Mistreatment and Response in New York City, Initial Lessons. This article will provide you with information beyond what I presented on today. Alyssa Ellman spearheaded the writing of this paper with Tony Rosen, a physician at Weill Cornell Medicine, and they did this in record time. Carl Pillemer, another co-author, helped to find a journal willing to publish the article quickly so it could have relevance to other communities. So thank you to Carl. Alyssa's on the call today and will stay on to answer questions as I have to jump off early, unfortunately. And this is just information on my organization, the New York City Elder Abuse Center, and that's my email address. And would love to meet people online if you care to write. And that's it. Thank you so much. And sorry for the ruffling of the papers or whatever it was.
Thank you very much indeed, Risa. That was great, and I'm really sorry that you have to disappear. But I know that your time is very stretched at the moment, and you're going to need to leave very shortly. But as you said, Alyssa is on the call on the webinar, and will be able to answer some questions. And I guess also that Carl may also be able to assist in relation to what's the situation in New York. So thank you very much indeed.
Thank you so much. Goodbye, everyone.
So we've come to the part of our session when we have an opening for questions and answers, and also for some more general discussion if we're able to get to that point. We've got quite a lot of questions already. And so one of the things that I wanted to ask, which is specifically in relation to the situation in Mexico, is a point raised quite early on in the session, which was about the fact that the data for Brazil show that more than 70% of the COVID-19 deaths are of people aged 60 and over. But from what you'd said, Marisa, obviously it's a lesser number in Mexico. So the questioner was asking for your observations on that, and also, how reliable the official data might be.
Okay, thank you. This data is not completely, from my point of view, is not completely reliable, not because of the government is trying to hide information or something like that, not, but because our system has a weakness, especially in the systematization of information around the territory, and especially in places where there are not presence of the health system. So I think there is a sub-register of people that maybe have been dead because of the COVID-19. That's my appreciation. Mm-hmm.
Thank you, Marisa. I know that we also have Veronica Montes de Oca on the call, and I don't know if she's able to unmute and add to whether she wishes to add anything to what you've said.
Hi, I am muted, Veronica, so she can talk.
Sorry, I am staying. Well, well, we have different factors in Mexico because effectively we have data, information, official information, basically, but we have in different ways the information is updated. No, that is the first reason, for example, for the register. But in the first stage of this moment of the lockdown, we have the same interpretation like the Europe. The older persons dead and is primarily the graphics, the amount, but when they disagree the groups of age, looked at the men and with a lot of morbidity have more death, more confirming case with COVID. And that and all the new discourse of the official government said is the multimorbidity, the first cause for to stay sick and dead. What is the problem? The problem is in the own interpretation, the informal workers, because they don't lock down. They need to work because they need money day to day. And it's a new position of the risk in Mexico, especially in the urban areas. Another very important thing is because the official discourse of the president at the first moment of this pandemic said, please care your parents, your older parents, and lock down immediately because it's the first group to be with contagion. And that's everybody, obviously, lock down the fathers, maybe provoke in different forms elder abuse, but these cures of the older persons in Mexico, is very positive, very legitimate, maybe with extremely paternalism and stigmatization, because everybody imagined the older person's independence form because the poverty and the inequality and the under coverage of the social security is very strong in Mexico. I suppose the inequalities and the violence for the narco traffic and the feminicides are very, very strong events, more important maybe than the COVID. But please take a note, this is the acme of this event in Mexico. We need to down the curve, the graphic, no, because this moment is very, very important, but we suppose the next moment are worst. We need to observe what happened, because maybe we need rebrotes, no, I don't know how to say that, again and again, because the people needs work in the formal market and needs to break the lockdown, no? And obviously that's our structural violence. It's another kind of abuse in the structural way, but it's very, very important to note these appreciations. Sorry, I think that.
Thank you very much, Veronica. If we move to the next question, which is a more general question that all the panelists might be able to respond to. This is from Roxanne Jacobs, and her question is, can you perhaps tell us a bit more about how persons living with dementia and their caregivers, either formal paid caregivers or informal family caregivers, are coping during the COVID-19 lockdown? And that she's wanting to know about those cared for in their communities, living at home or with relatives, and those in long-term care facilities. So it's what sort of reactions there might be to being confined. and what might be happening for individuals with dementia. Elsie, would you like to respond first to this question?
Yes. We do not have lots of information from nursing homes right now, long-term care facilities, as most of them still decline visitations. But the data I got from Hong Kong is that so far there is like 0 death in nursing homes in Hong Kong, which I personally is impressed. And most homes in Hong Kong are designed in a way that without person with dementia from like going out on their own. So they have been in confinement in some ways. So they would like mask the door so that they don't know like how to go out. And what I heard informally is that older persons, they do not like wearing surgical masks. So right now it is only the staff who are still using surgical masks and gloves. And for older persons at homes, they are pretty much on their own with their family caregivers. Well, because before the COVID-19, they could go to respite care, daycare services, or community centers for various types of services. But these days, because most services were suspended, they were pretty much just home with their family caregivers.
And do you have information yet, Elsie, about what might be happening, what the reactions of individuals might be to being confined for these periods of time, or do you think that that's something that will be forthcoming in the future?
We are actually loosening some of the policy. For example, the 4-person band of like gathering of 4-person or more, we have lifted that. So beginning, we are seeing that like the policy being like more relaxed. So hopefully, well, right now some of the services resumed, but I don't know when all the services will be fully resumed, but we are hoping that it will happen in the near future.
Thank you, Elsie. Marisa, would you like to say anything about the situation in relation to people with dementia in Mexico?
Yes, well, the pandemic revealed a reality that we knew and that no one has faced. The regulation and supervision of long-term care centers in Mexico doesn't exist. It's not possible nowadays to know how many people are institutionalized in private or religious long-term facilities. The capacity of the Mexican state for these long-term care centers is minimal. And in the case of mental institutions, it's especially painful since in Mexico, these spaces are per se ideal places for reproducing violence and abuse and mistreatment.
Yeah. Thank you, Marisa. I'm not sure whether either Elisa or Carl would like to or be in a position to say anything about the situation for people with dementia at the moment within New York. Elisa, if Lucas unmutes you, perhaps you might be able to say a few words.
Sure. Hi, everyone. It's really hard to really understand the impact of COVID on people with dementia in the community. We get a lot of patients who are brought to the hospital who are COVID positive and have dementia, and some can report on abuse and others cannot. What we've seen a lot of is individuals in nursing homes who become COVID positive. And that's been really challenging because a lot of the ombudsman and other advocates for individuals in nursing homes are not able to actually enter the nursing home. So that's been a unique challenge during this time. Carl, I don't know if you have anything else you want to add.
No, I think that would be pretty much it. And I know there are a bunch of other questions. I think you all have covered it quite well. I would say the same thing that, I think for nursing homes in which I work a lot, the issue of abuse prevention has kind of receded because they're in such a crisis mode here. So it's not, really actively in the discussion because they're more in a sort of crisis and survival mode at the moment. It's going to be interesting to see what happens when they move out of that mode.
Thank you. We have a brief question as well, which Elisa might be able to answer, which is Louise Belanger-Hardy asking for the title of the article that you wrote, Elisa. If you could just give the title, that would be very helpful.
Sure. It's the title is Effects of the COVID-19 Outbreak on Elder Mistreatment and Response in New York City, Initial Lessons. I can also type it into the chat if that's easier.
I think that would be helpful if you could provide the reference. Thank you, Elisa.
Sure.
Elisa.
Yes, I'll add it's fully open access, so anybody can download it.
Okay, I'm just scrolling through questions. So there's a question here which others may be able to, or respondents may be able to shine some light on. This is from Rabbi Deloso, which says, in Europe, COVID-19 vulnerable older population in many countries has been set at 70 years and above. Is there a country-specific reason why 60+ adults are considered at risk in both North and South America? Marisa, would you like to say anything? I think you need to unmute yourself, Marisa.
Thank you, sorry. In Mexico, the law establishes that the beginning of elderly is 60 years old, is in the law. So they establishes that age as the beginning of the benefit for receiving benefits and for being cared by the state.
So it's in line with government policies around when somebody's considered to be an older person?
Yeah, exactly.
And would that be the same for you in the US, Carl?
Yes, I think at least as far as I know. I don't know if Alyssa has a thought. Or maybe not.
It could be that Elisa's busy typing, writing the details about the article in the chat box.
No, I couldn't get off mute. No, as far as I know, yes.
Thanks very much indeed to all the panelists. And a further question here, which is, what do panelists think could realistically be done to protect older people when detection and measures to safeguard older people are undermined by the pandemic, maybe particularly in developing countries? Are there particular things that might be done in terms of assisting with detection, but also in relation to safeguards to protect people? Elsie, would you like to have a stab at that question?
I think it is a mistake to assume that like elder abuse detection and intervention is like responsibility of a particular profession or particular sector in a society. From our experience, we conducted some interviews with older persons who sought help. So older persons living in shelter, and apparently people who identify these cases, they come from all walks of life, janitors, people, neighbors, janitors, or just random friends and people they bump onto in the street. So I think it is collective effort that will help with elder abuse detection and intervention.
Thank you, Elsie. Marisa, do you have a comment that you wish to make here? Or do you want Carl, do you want to say something first?
Yeah, I just had a quick thing. I was going to sort of second what Elsie said, and maybe Alyssa could say, I think, in the paper, we tried to talk about a detection. I think that the use of hotlines is very, very important. I think because that is one good way that detection can take place. I also agree with Elsie. I think this is a key moment for neighbors, family members, other people who are involved. I think a bigger problem, though, is especially with social distancing, et cetera, is helping professionals into the home as needed. And it certainly makes it difficult right now to remove a person from home. But I would say, and I'm curious what Alyssa would think, that, the hotlines, I'm sure, are being very, are really, really needed now in terms of detection. And maybe if those don't exist in locations, now might be the time to have a central clearinghouse for people to either call in about abuse or possible abuse, kind of using other technology that we have. I'm sure that would be challenging in developing countries for sure.
Yeah, this is Alyssa. I think Carl's absolutely right. I think helplines are a great resource if possible. Another way to kind of do some surveillance is having, I know at the Wright Center, which is a geriatric outpatient clinic in New York, the social workers and physicians are doing a lot of outreach to their patients, trying to speak to them on the phone quite frequently and much more frequently than under ordinary times to make sure that they're safe and that their needs are being met. And I know in maybe more developed countries, a shift to telemedicine and using medics to go out to the home to do wellness checks and using those types of resources might be something that in more developed countries, people are going to start exploring.
Thank you, Elisa. Marisa, would you like to add in anything here?
I just add that providing information to the social network is a very good strategy to respond to this information crisis for the elderly by establishing a very good communitarian organization in microspaces in order to give the information, because in urban places the use of the phone is very simple, but in rural places it's not necessarily the best strategy. So communitarian organizations could be a very good answer.
Thank you. I guess there are difficulties that people might, particular difficulties that older people might face in terms of accessing helplines, either use of the telephone or being able to do so in a safe way. And that obviously could affect people in both developed and less developed countries. So there are particular issues, I think, in relation to, I think encouraging people to use helplines is absolutely what we need to be doing, and developing helplines where possible. But it could also be that, we need to acknowledge that there might be some risks. So alternative forms of information would be clearly very important. We have a question here from Santiago Cambero, who says that they are interested to know about how the normal population could have faced these sort of ageist practices in each country where people are working against elder abuse, and whether there's sufficient awareness of this issue as a social problem or not within communities and within different countries. Elisa, would you like to say anything about public awareness and awareness at population level for the issue of elder abuse?
Yeah, I think obviously raising awareness and doing as much outreach as possible is key. A lot of, at least in the US, a lot of medical providers and professionals that are trusted by older adults are not aware of elder abuse and how to intervene. So we've tried to do our best in our small community to go around educating home health aides, physical therapists and occupational therapists, nurses, doctors, anyone who might come in, getting in touch with this population to keep an eye out, because I think the best way to identify or to intervene in these cases is for people to really be looking for it, and also being able to provide people who identify it with the support and resources that they need to properly intervene.
Thank you, Elisa. Marisa, would you like to add anything about awareness about elder abuse within Mexico?
Yes, I think this pandemic gave us an opportunity to visibilize this reality. So this is the moment probably to design strategies of formation and education to different members and sector of society in order to show what is the result of being an ageist society. If we weren't, this situation nowadays would be different.
Thank you.
I add one quick thing. Two thoughts. One is, I think that it is really key, and for the elder abuse community around the world to be really aware of the increasing danger of ageism. So the WHO Global Initiative on Ageism, as well as a group that Peter Lloyd Sherlock has helped to bring together, is trying to look at how this situation is leading to dangerous rises in ageist thinking, ageist policy. So given that increases in ageism can be related to elder abuse, I just would underscore that. Perhaps if this was mentioned and I missed it, I will say too, another issue that people should be aware of is the increased possibility for financial exploitation when there is massive unemployment and people are one person's, for example, the Social Security check might be available. I think there are a number of people who think there's going to be a rise in financial exploitation of older people, both in higher and also lower and middle income countries. And that's something I think that is going to have to be addressed. It didn't exactly relate to ageism, but it struck me too as part of the earlier discussion.
I think it's very definitely related to awareness about elder abuse in more general terms, however, Carl, so thank you for raising that. And one of the things that I'd like just to sort of interject here from UK perspective is that we've seen a marked increase in the extent and nature of scams against older people, financial scams, people being contacted by individuals. So this isn't relatives who are financially abusing individuals, but it's other people who are facing financial security or lost their jobs or whatever, who are contacting older people and, for example, saying, you should have had a letter from the government about the fact that you're particularly vulnerable and you should be shielding. We need your details so that we can follow up, and then extorting money out of individuals. Elsie, I don't know if there's anything that you'd like to add here about this particular issue.
Yeah, I want to follow up with the scams you talk about. In Hong Kong, we actually have cases where people are wearing like lab coats, surgical masks, cover up their face, and then knock on the doors and tell people like, I'm sent by officials and I'm going in to help you clean up your place to make sure your place is COVID-19 proof. And then they break in and take whatever they want. So that happens. I think that happens across countries and cultures. I think somehow like ageism and elder abuse has been there for a very long time. I think it is time. I think COVID-19 is a very good opportunity for us to see how important it is and like the very huge impact it has on our older population. And I think the next step would be for us to put it on a priority list.
Thank you, Elsie. I think sort of following on from what Carl had said about, ageist thinking and the way that ageism is playing out, what we also need to bear in mind that in some senses, the practice of ageism, I think, very definitely, it leads to some sort of permissiveness in relation to elder abuse, because what it then means is that it doesn't matter what is happening to older people, and that older people can be treated as if what happens to them isn't of any great consequence in terms of either society or for individuals. So I think that the link between ageism and elder abuse is in a sense being very dramatically played out here in the COVID-19 pandemic. So, I think we need to be very watchful and be working on measures that actually will try and address some of these issues. I'm scrolling down the list to see what sort of questions we're getting. We have a question here from Georgina Veitch about what should the priorities be to tackle issues of neglect in public and private long-term care facilities, particularly in low and middle income countries. So I'm not sure if you would like to pick up and try and respond to that, Marisa.
The thing is, first of all, with long-term places is that we need in our countries a regulation and the constitution of a national system of care, not only for these places, but also to support the caregivers, the informal caregivers in families. So I think this is a very good opportunity to do that and to increase the capabilities of caregivers and to support them in order to have these short break times and give them all the support necessary to prevent the breakdowns and all that stuff.
Thank you very much, Marisa. I'd love to be able to ask others for their opinions, but I've just glanced at the time and realised that we're just about out of time for our webinar. Unfortunately, we've only scratched the surface in terms of the questions and the ability of people to answer. But I'd like now to ask Peter if you'd like to come in and wrap up the webinar for us. Thank you.
Thank you so much, Bridget, for doing a really good job of chairing and fielding the questions. And thank you so much to our excellent speakers. Clearly, this issue is a major concern, and it's clearly an issue which is becoming increasingly difficult to tackle and to resolve. I guess at least what we can try and do is to promote general awareness and awareness among professionals, so that when there are occasionally opportunities to detect different kinds of elder abuse, these opportunities are not missed. This is when I normally talk about our next webinar, our forthcoming webinars, but actually as of yet we don't have a topic for our webinar next week or moving forward. This is largely because I've actually kind of run out of steam a little bit in terms of organising these and in terms of asking people to do them. And in fact, it was Bridget and Carl Pillemer who mainly organised this week's session. And so all I'm going to do really is say that if you find these weekly webinars are useful, please can you access this link, which enables you an opportunity to suggest yourself or another person as a speaker, or to organise webinars around particular topics related to older people and COVID in low and middle income countries. It is possible that we will be having a webinar in the next week or two, and at the moment the most likely topic will be the effect of lockdowns on older people in Africa. As it happened today, The Lancet was published, its weekly edition was published, and on the front cover, it referred to the importance not to neglect the potential calamity that COVID could inflict on the continent of Africa. It made specific reference to the effects that it may have on health outcomes for children, for informal sector workers, but once again, absolutely no reference was made specifically to older people, who of course will bear the brunt of mortality in Africa as they do elsewhere in the world. So this has made me think maybe we need to focus on that region in the next week or two. We did last Friday have an excellent webinar in Spanish and Portuguese on coronavirus, specifically in Latin America. And some of the materials from that webinar have now been published in the form of blogs, and more of those presentations will be published in blogs in English and in Spanish and in Portuguese over the next few days. So that's all I've got to say. Thank you so much for making this another great webinar. Last slide, please. And finally, I would like to thank particularly Lucas, but a number of other people who've made very important contributions to the ongoing activities of the global platform and of these webinars. So thanks, folks. Stay well and stay safe, and see you soon. Bye.
Thank you.